Lymphoid malignancies is a topic which encompasses lymphocytic leukemia and lymphoma and represents a diverse group of blood cancers originating from lymphocytes, a type of white blood cell crucial to our immune system. These conditions range from slow-growing, often indolent forms to rapidly progressive diseases. Understanding these malignancies is vital for any healthcare professional as they can present in various clinical settings, from routine checkups to emergency admissions. Whether you're a GP managing initial presentations or a medical student aiming to understand the fundamentals of lymphocytic leukemia and lymphoma, today's episode is essential. Today we're here to break down this complex area with an interview with Dr Joanna Czerwinski, a haematologist specialising in this area. Welcome to Aussie Med Ed. Good day and welcome to Aussie Med Ed, the Australian medical education podcast designed with a pragmatic approach to medical conditions by interviewing specialists in the medical field. I'm Gavin Nimon, an orthopaedic surgeon based in Adelaide, and I'm broadcasting from Ghanaland. I'd like to remind you that this podcast is available on all podcast players and is also available as a video version on YouTube. I'd also like to remind you that if you enjoy this podcast, please subscribe or leave a review or give us a thumbs up, as I really appreciate the support and it helps the channel grow. I'd like to start the podcast by acknowledging the traditional owners of the land on which this podcast is produced, the Kaurna people, and pay my respects to the elders both past, present and emerging. Well, it's my pleasure now to introduce Jo Czerwinski, a haematologist who works at Flinders Public Hospital who specialises in haematological malignancies and other haematological conditions. Jo, thanks very much for coming on Aussie Med Ed. Perhaps you can go through, in your mind, how you divide up these haematological malignancies. Well, I used to think of them as leukemias versus lymphomas, but I understand you go through lymphoid versus myeloid type conditions as a way of considering them.
Thanks, Gavin, for having me. So, yes, I often divide them into lymphoid and myeloid conditions because haematological malignancies begin from the hematologic stem cell, which is at the top end of the rung, and these divide into two types of stem cells, the lymphoid stem cell and the myeloid stem cell. From the lymphoid stem cell, you generate B cells, T cells, and natural killer cells. They're the different subcategories of lymphoid cells. And from the myeloid stem cell, you have the red cells, all of the different granulocytes, and the platelets. And as we go through the different types of malignancies, I will be able to show where these malignancies have generated along those development lines. Excellent.
So I understand the lymphoid ones were the ones we're going to talk about today. They're also the ones that are actually involved in development of lymphomas as well, which is a different type of condition as opposed to leukemias. How do you consider leukemias versus lymphomas, and how do they vary for the medical student?
Yeah, so leukemia comes from the Latin word of leuc, which is white cell, and emia meaning in the blood system. So leukemias are just the cancer is in the blood system, whereas a lymphoma is in the lymphatic system. So you often find it in lymph nodes as well as the spleen and the liver, which are part of that lymphatic. The conditions can overlap when it comes to the bone marrow.
Right. And I understand you can't get myeloid cells in lymphomas. It's purely from the lymphoid type cells.
That's correct. Although the bone marrow microenvironment, let's call it, has both types of cells. So you can have changes to the myeloid component with lymphoid conditions.
I'd like to let you know that Aussie Med Ed is supported by HealthShare. HealthShare is a digital health company that provides solutions for patients, GPs and specialists across Australia. Two of HealthShare products are Better Consult, a pre-consultation questionnaire that allows GPs to know a patient's agenda before the consult begins, as well as HealthShare's Specialist Referrals Directory, a specialist and allied health directory helping GPs find the right specialist. So in your experience, how often do these conditions present in everyday practice? I'm curious because they seem quite rare in general practice, but I'd like to get a sense of what to look out for.
From my experiences speaking with different GPs, it seems to be that each GP may see 2 or 3 cases in their patient cohort. So it's not very common from a GP perspective. It's very common from my perspective, though. The most common ones that we'll be speaking about today is chronic lymphocytic leukemia, as that's one of the most common lymphoid conditions that we see.
Although I understand the acute lymphocytic leukemia is actually the commonest cancer in the young children.
So acute lymphoblastic leukemia is an aggressive form of lymphoid cancer, and it has a bimodal development, that in children and that in much older adults as well.
We'll talk about, first of all, how they may present initially, and then talk about how you classify them down into those sort of different areas.
Yeah, sure. So leukemias and lymphomas can present with very few symptoms to begin with, especially if they're chronic versions of disease states. So chronic lymphocytic leukemia, for instance, can present incidentally just through a blood count, where the patient has gone to their GP just for a regular checkup. But when these conditions become more aggressive, they start to present with what we term constitutional symptoms. And this includes dramatic weight loss where the patient is not dieting. It can include fevers and night sweats, and the night sweats are drenching where they have to change their pajamas or their bed sheets. And it can come with severe fatigue where they're essentially bedbound or couch-bound for the majority of the day. Other ways in which patients can present is recurrent infections, which they can't get over, and they need multiple rounds of antibiotics. And they can sometimes present with cytopenic complications of anemia needing transfusion, thrombocytopenia where they come out in a petechial rash or excessive bleeding and bruising, and as we mentioned, infections where they have low white blood cell counts.
Excellent. From what I can understand in my reading, the simple blood test to see a complete blood picture can often pick up the diagnosis straight off.
Yeah, very often when lymphoid condition spills out into the bloodstream, it can be seen by a simple blood test and a blood film analysis. So the laboratories will look at a drop of blood under a microscope and can see the normal lymphoid cells as well as the abnormal forms.
Okay, so I'm interested in how you approach the classification once you've got the initial findings. What guides your decision-making when identifying the specific type of lymphoid malignancy?
So for the lymphoid conditions, acute lymphoblastic leukemia is sort of the prototype of acute illness. It usually presents within only a couple of weeks from development to full-blown symptoms. And usually the acute lymphoblastic leukemias will present with a pancytopenia, so low red cells, low neutrophil counts, low platelet counts, and they may have lymphoblasts in their circulation. That's how the diagnosis is made. To further go along, obviously this is a bone marrow malignancy and it is a leukemia, so it's spilt out into the blood system. So oftentimes you can get a diagnosis by complete blood examination and flow cytometry, which tells us the clone of that cell. Now, to go into a bit more of the classification, when we look at the lymphoid stem cell and how it generates into more mature cells, we think about it as where that cell is in its natural state. So the lymphoid stem cell is where acute lymphoblastic leukemia originates from. It is a mutation in that stem cell. Once the stem cell goes through its normal development and exits from the bone marrow, then you have your mantle cell lymphomas and some variations of chronic lymphocytic leukemia before that lymphoid cell then enters the lymph node to start its development and its training, as it were. And in the lymph node is where you get a whole bunch of the different types of lymphomas. Now, there's more than 80 different types of lymphoma, and they're classified into B-cell lymphomas and T-cell lymphomas, and they range in aggressiveness from indolent to more aggressive lymphoma types. And then once the lymphoid cell has undergone its training and left the lymph node back into circulation, you then have other forms of chronic lymphocytic leukemia, and you also have plasma cell myeloma and other plasma cell disorders, because the end differentiating lymphoid cell is a plasma cell, which is capable of producing antibodies. So to get back to your earlier question about how I would undergo investigations, they all start with a CBE, they all have a blood film, and they all have flow cytometry from peripheral blood. Because even some lymphomas, they can spill out of the lymphatic system and into the blood, where we can easily pick them up through flow cytometry.
What's the importance for classifying them? If they all present with a similar way and they all can cause anemia and infections, why is it so important to classify them into these different subgroups?
I guess because the treatment is very different amongst the different subtypes of lymphoid disorders. So how I would treat an acute leukemia versus a chronic leukemia versus a B-cell lymphoma versus a T-cell lymphoma.
And the stages between acute and chronic are really how quickly they present in that sense?
It's a crude way of thinking about it, yes. So anything acute or aggressive has usually been there for a very short period of time before a patient presents, whereas a chronic indolent process can be there for many months to even years before a patient is aware of their condition.
What's the cause of the aplastic type effect that you get from leukemias and lymphomas in that sense? Why does that occur?
So if we think about the bone marrow being a production factory for red cells, white cells, and platelets, if you have an acute leukemia event, usually the lymphoblasts in this scenario will crowd out the bone marrow, leaving very little space left over for normal cells to be created. So oftentimes it's because of, say, 80% of the bone marrow is filled up with blasts, and that only leaves 20% left over for normal myeloid cells, which is why you get the aplastic appearances.
I'd like to let you know that Ozymed is sponsored by OPC Health, an Australian supplier of prosthetics, orthotics, clinic equipment, compression garments, rehabilitation devices for doctors, physiotherapists, orthotists, podiatrists and hand therapists. If you'd like to know what OPC Health offers, visit opchealth.com.au and view their range online. Okay, so I'm curious about this staging. How do you determine the stage of condition after you've classified it, and what role does that play in treatment planning?
So the leukemias are staged differently for the acute and the chronic lymphoid leukemias. So acute leukemia, we would do molecular or genetic testing from their bone marrow to determine whether they're aggressive, intermediate, or low risk genetics, and that will then define whether they go ahead with a bone marrow transplant in their course of treatment. For the chronic lymphocytic leukemias, there is what are called Rye and Binet staging systems, and they are based on how many cytopenias the patient has, how many lymph node areas are increased by palpation, and whether they have hepatosplenomegaly. And so most patients that I see are actually stage 0 from those systems, meaning that the only syndrome they have is their lymphocytosis. They have otherwise normal blood counts, they don't have enlarged lymph nodes, and their liver and spleen is normal. So those are the staging systems for the leukemias. For the lymphomas, it is by Ann Arbor staging systems, which is usually through CT guidance or PET guidance, depending on the lymphoma type. So stage 1 is one group of lymph nodes, say in the cervical area. Stage 2 would be 2 separate areas of lymph nodes, but on the same side of the diaphragm. Stage 3 is that it's crossed both sides of the diaphragm, but it's still within lymph node areas. And stage 4 is if it's invaded into other organs, such as bone marrow, spleen, and other organs like kidneys, for instance. So those are the staging systems for lymphoma. And finally, for myeloma, there is the revised international staging system, which is based off of a few different markers like albumin, LDH, the genetics, and the beta-2 microglobulin.
What's the cause of these conditions? Is it because there's such a high turnover of these blood cells that they've got a greater chance of causing malignancy or a genetic transmutation? Or does it all relate to a congenital cause, or is it some sort of exposure cause that causes them?
Most of these conditions are diagnosed above the age of 50, so I like to think of them as wear and tear conditions, where the body has undergone, say, 60 years of life, and along with that it has acquired mutations. There are some circumstances where there are inherited disorders, so particularly where we mentioned acute lymphoblastic leukemia in children. There are certain circumstances where it's related to a genetic mutation when they were born.
Okay, I understand Down syndrome is actually a higher risk of it as well. Is that correct?
Yes, absolutely. So it is one of the causes of inherited acute lymphoblastic leukemia.
So, Joe, are there any other exposure causes that can lead to these conditions as well? Is there anything you might see as an adult haematologist that can be related to this condition?
Certainly, if patients have received chemotherapy or radiotherapy for other conditions, say breast cancer, for instance, then there is an increased risk of developing lymphomas and leukemias in general. The same thing goes for some of the immunotherapies, for instance, methotrexate, used commonly for rheumatoid arthritis. There is an increased incidence of lymphomas following methotrexate use. In general, there is a tendency with autoimmune and inflammatory conditions to have a higher incidence of lymphoma. And there is also exposure risks.
I also read that smoking might be a factor as well. Is that a big factor, or is that only a slight association?
It's a slight association. It's not as strong as, for instance, lung cancer or head and neck cancers.
So once you've got a diagnosis and you've classified it and you've gone through the staging, what are the treatment options? If we start with, say, the acute episode, what's the sort of thoughts that go through the process of actually treating such a condition?
So for acute lymphoblastic leukemia, the treatment is often many months of chemotherapy, usually in the hospital for majority of that time, as the induction chemotherapies are multi-drug, multi-day therapies, and they're often quite sick in hospital, needing to manage their febrile neutropenias, manage their toxicities from their chemotherapies. Many of the acute lymphoblastic leukemia patients will undergo an allogeneic stem cell transplant as part of their therapy, and that can be considered sort of their consolidation treatment. And some patients following an allogeneic transplant or following their induction chemotherapy will also have what we call maintenance therapies. So the acute lymphoblastic leukemias are very different from the lymphoma in terms of the intensity of management. If we think about diffuse large B-cell lymphoma and follicular lymphoma as the two prototype lymphomas in B-cell malignancies, diffuse large B-cell lymphoma is R-CHOP, gold standard, and that's the first-line therapy, and that's delivered 1 day every 3 weeks for a total of 6 rounds. And most patients will go into remission from just that course of chemotherapy. But there are some patients which will be resistant and will need to undertake an autologous stem cell transplant in their future. Follicular lymphoma is a much more indolent lymphoma, and not all patients will need to undertake treatment straight away. And you'll often see a lot of this watch and wait program that haematologists prescribe. But if a follicular lymphoma is needing treatment, it is because it is symptomatic and causing that patient harm. So for those indolent lymphomas, we only treat when the lymphoma is causing an actual problem to the patient.
Right, so that's different to the acute lymphoblastic leukemia where they go more aggressive type treatment in that scenario. These lymphomas, do they occur in children as well, or are they more in the adult age group?
There are some Burkitt lymphomas and follicular lymphomas that can occur in teenagers. Usually they are, again, older populations, but diffuse large B-cell lymphoma can occur, from 30 years onwards as well.
So we've got our acute lymphocytic leukemias occurring in the young children, which have a quite aggressive treatment of chemotherapy, and I believe it has quite a high success rate in cure. Do they involve an induction, a consolidation, and a maintenance type of treatment? Is that correct?
Yep.
Then we have our lymphoma group. And what age group do the lymphomas, did you say they occur in?
Some types of lymphoma can occur in teenage years, but most lymphomas will occur above the age of 40 or 50.
Okay, and they're divided up into various forms of non-Hodgkin's lymphomas or Hodgkin's lymphomas. And the ones you were mentioning before are non-Hodgkin lymphoma styles. Is that correct?
That's right, yes.
And what determines the difference between a non-Hodgkin and a Hodgkin's is the presence of a type of cell. Is that the way it goes?
So they're called Hodgkin cells or Reed-Sternberg cells. You may have heard that in reference in a textbook, but they're very large cells that have a particular histological feature when they're looked at under a microscope.
Is that the one with the two nuclei or something from memory?
They look like owl's eyes.
So the non-Hodgkin lymphomas involve these large type of B-cell lymphomas. You said there's 60 various forms of it. Is that correct?
80 different forms across B-cell non-Hodgkin lymphomas. And then there's also the T-cell non-Hodgkin lymphomas as well.
Right. NK cells also included in this group?
Yeah, they're called natural killer cells. They're very uncommon lymphomas and leukemias, and they predominantly present as leukemias.
Okay. So either B-cell or T-cell, predominantly B-cells, and they present in the older age group. If they actually get missed and are picked up late, I've read somewhere they can present with bowel obstructions or with respiratory distress from collections around the lungs. Is that correct, or is that a pretty rare finding nowadays?
I mean, it's not rare to me, but it will be rare to the general population. So some types of aggressive lymphomas like Burkitt's and diffuse large B-cell lymphoma, we've been able to pick them up as stage 1 disease, but in the bowel. And there is this theory that if patients have pre-existing Crohn's disease or ulcerative colitis, or they've had some other immunodeficiency, that it can occur in the bowel as the primary site. Okay. These are still treated the same way as if they occurred in the lymph nodes, though. There is also presentations in the lungs. So superior vena cava obstructive syndromes can often present with shortness of breath and chest tightness. And the Hodgkin lymphomas in particular can present with mediastinal masses.
With the difference between non-Hodgkin's and Hodgkin-style lymphomas, is there Hodgkin styles? Is there only one type, or are there various subforms of Hodgkin's as well?
There are 5 different forms of Hodgkin's. Most of them are under what we call the classical Hodgkin presentations, and the description differences between them is how they appear under the microscope from their histology samples. The one that's a bit different is the nodular lymphocyte predominant Hodgkin's lymphoma, because this is treated more like your B-cell lymphomas like DLBCL, for instance.
DLC, what does that stand for then?
Diffuse large B-cell lymphoma.
Sorry. So, and the Hodgkin's, have they got a worse or a better prognosis than the non-Hodgkin's?
Generally very good prognosis. So especially this also has a bimodal presentation in the population. So we can see 20-year-olds with them and 80-year-olds with them. And how well you do and how your prognosis is based a bit on your fitness. So a young person with Hodgkin's lymphoma, 90% cure rate with standard treatments. An older person with Hodgkin's, because they can't have the standard chemotherapies at their ages, they are less survived, but still reasonable prognosis.
And the actual percentage of people with Hodgkin's versus non-Hodgkin's, is it significantly greater numbers of non-Hodgkin's or Hodgkin's?
Non-Hodgkin's is certainly much more common.
And once a diagnosis is confirmed, how do you start mapping out the treatment plan? What are the main factors that guide your choice of treatment?
So often what can help with a referral to a haematologist is by having the basic complete blood examination and full biochemistry with the LDH, as well as if there is a lump that is easily accessible to biopsy, a core biopsy is going to give us a world of information, because that can already start subtyping what type of lymphoma it is, how aggressive it is, and how soon does it need treatment. And often what I encourage GPs to write on their referral is whether this patient has constitutional symptoms or not, because that's going to dictate how quickly I need to see the patient as well. There are certain other tests that can be helpful, so flow cytometry from peripheral blood, but even if that's negative, that doesn't exclude the probability of a lymphoma or leukemia.
So flow cytometry, is that where the blood is passed through a tube and a computer analyzes the type of cells they are, or is that how it works?
Yeah, roughly. So it is, the blood is pulled through a machine in single file, and a laser is pointed at these cells, and with all the refracting light from it, it gives off a certain cell signature. And what we're looking for is a clone of B cells. So, for instance, in chronic lymphocytic leukemia, B cells will express CD20 and CD19. That's part of being a B cell. And chronic lymphocytic leukemia will have another marker called CD5, which will be positive, and CD10 will be negative. And that begins sort of the clonality of that cell. What defines a clone of a cell is whether they're expressing a certain light chain, so whether they're expressing kappa or lambda.
You mentioned also getting a core biopsy. Is that something that a GP just takes out a needle and puts it into a lump, or is it done by ultrasound guidance or CT guidance? How is it actually physically done?
So I recommend that GPs refer off to a radiology company for an ultrasound-guided core biopsy.
We also mentioned in passing was the bone marrow biopsies as well. How are they actually physically done? Is that something that needs an admission to a hospital and an anaesthetic?
So in South Australia, we do them under sedation. So it is like a day procedure. A patient will come in fasted and they'll have the anaesthetic team performing the sedation and a haematology team performing the actual bone marrow. The procedure itself is only a 15-minute procedure and involves taking a blood sample and a bone sample from the posterior superior iliac spine.
Excellent. And one question that came to mind also is, when I was doing this reading, as a surgeon, I felt sort of left out of the process. It doesn't sound like often surgery is required in these conditions.
There certainly is circumstances where we need to involve a surgeon. So where we mentioned Hodgkin's lymphoma before, Hodgkin cells aren't actually not that popular in the actual core biopsy specimens. So sometimes a core biopsy will be performed and the specimen quality is quite good, but it still misses out on those key Reed-Sternberg cells. So often we will refer to surgeons to perform an excisional lymph node biopsy, where the whole lymph node is then sent away for analysis. Similarly, I need a cardiothoracic surgeon for the mediastinal lymph nodes, if that's the only area of disease. Sometimes, colorectal surgeons are needed for the bowel specimens because they've come in with obstruction or perforation. And sometimes I need even orthopaedic or neurosurgeons for the vertebral lesions that may present.
Excellent. All right, so we've got our biopsies. We're going to talk about our treatment plans then, and they obviously vary depending on all the different classifications. What are the main headings for treatment options for treating these conditions?
So the stock standard would be chemotherapy, and that's quite common for the aggressive forms of cancers. And usually it's a protocol of several cycles. Many of the protocols involve hair loss, nausea, vomiting, the usual side effects from chemotherapy. But over the last decade or so, we've developed quite a lot of different alternative treatment options. So R-CHOP being the sort of prototype involves rituximab, which is what the R stands for, and that's a monoclonal antibody. So it is actually targeting CD20, which we mentioned before. And so any of the B-cell malignancies that express CD20 can be targeted with rituximab. And certainly for some of the more indolent lymphomas, you can use rituximab by itself without chemotherapy. So chemotherapy, monoclonal antibodies. There are also immunotherapies or targeted treatments as well. So chronic lymphocytic leukemia has emerged as quite a popular disease to try and avoid chemotherapy. We know that chemotherapy works, but chemotherapy is quite a slog for patients and has long-term side effects. So there's been quite a focus over the last decade in trying to transform the treatment algorithm for patients. So there's these targeted agents which are called Bruton tyrosine kinase inhibitors, or BTK inhibitors, which is actually targeting an area of the B-cell receptor to turn off proliferation and to turn off adhesion factors. So the three BTKs, which I use quite often, are ibrutinib, acalabrutinib, and zanubrutinib. You'll notice that all of them end in nib. So these three agents, they act on CLL by releasing all of them from the lymphatic system, from the bone marrow system, so that stops the adhesion to those areas. And then they stop proliferation, so they make these cells inert. And the body eventually destroys them just from it being in circulation. So it's quite a common treatment, and it is being expanded into other areas. So Waldenstrom's macroglobulinemia, which is another form of lymphoma, and mantle cell lymphoma, we now are able to use these BTK inhibitors in those diseases as well.
Amazing. I keep getting this common theme that keeps appearing when we talk about cancers on these podcasts is actually the importance of the patient's immunity themselves, their natural immunity.
It is certainly something that I discuss with all of my new diagnoses of any form of cancer with my patients. Lymphoid malignancies are a particular kettle of fish that we need to discuss. So it doesn't make a difference whether it's a B-cell malignancy or a T-cell malignancy. There is damage to the immune system talking to itself. So B cells and T cells, their normal approach to infection, to foreign bodies, is the B cell will present antigens to the T cell, and the T cell will then destroy those antigens and associated pathogens. And this is a broken system when you've got a malignancy from either the B cell or the T cell side. So one thing that I often talk to with patients is that regardless of their lymphoid malignancy, they are now considered immunocompromised. And there are three things that I can do for that patient. I can test their immunoglobulin levels, and if the immunoglobulin G level is low, there is replacement available in the form of intravenous or subcutaneous immunoglobulins. There is the system of needing to have easy access to antibiotics and antivirals because they're more likely to suffer with infections at a more severe degree than a patient with a normal immune system. And there is vaccinations. So we do not give any live vaccines because there is a great risk that the patient will actually develop the disease that the vaccination was intended for. But I tell all of my patients to be up to date with the influenza vaccine, COVID vaccine, the latest shingles vaccine, which is called Shingrix, and then the pneumococcal or pneumovax vaccine. So that's one part of the immune system that is in a way broken. The other part of the immune system that is also broken is what's called tumor surveillance. So that same B cell presenting antigen to T cells, that presents tumor antigens as well in the normal healthy individual. And that system is again broken. So any patient with any of these lymphoid malignancies has an increased risk of a second malignancy occurring. So I tell patients, be up to date with your age-appropriate malignancy screening. So that's bowel cancer, prostate cancer, breast cancer, cervical cancer, and must not forget about skin cancers.
You talked about the use of chemotherapy as well, but then chemotherapy can also be associated with the cause of leukemias and lymphomas as well. So can the actual drugs you use to treat the leukemias cause a cancer too in that sense?
Yeah, absolutely. So once a patient has undergone chemotherapy, and regardless of if they've achieved a cure or remission, I do tell them that it is important to keep up to date with their normal malignancy checks, but also to have a blood test every year, just a complete blood examination and biochemistry, because we have found some patients have had chemotherapy and it's damaged their bone marrow in other ways. And so we can often see myelodysplastic syndrome and acute myeloid leukemia developing as a result of prior chemotherapy.
Well, actually, we mentioned targeted therapy and use of monoclonal antibodies. Is that like a tablet you can just get over the counter, or is it specifically produced for one individual patient? and they have to have a genetic testing to actually produce it. How do these medications work?
So the monoclonal antibodies are infusions, and so long as the patient has a CD20 malignancy, we can apply for it. It is dosed based on their body surface area, so their height and weight are taken into account. For the targeted treatments like the BTK inhibitors that I mentioned, that is an authority script that only a haematologist can apply for, but it is the same dosing regardless of the patient indication and regardless of the patient weight.
So the immune therapy then, the actual targets are actually a common form of therapy. It's not, I always had this idea that you might take the patient's blood, work out what the immune response would be and target that particular individual.
I would hope that will be the case in future, where we have more tailored approaches to patients. At the moment, we're using the genetic test predominantly to give us the risk profile of the patient. So if they're high risk, I know that they may not respond to chemotherapies, and I would more likely use the targeted treatments or immunotherapy approach. And similarly, if they're low risk, that gives me prognostic information and tells me that it could be a while away before this patient needs treatment, and that's a good thing.
Joe, when we're talking to a lot of other physicians about the treatment of different malignancies or even just conditions in general, another common thing that comes up is the use of multidisciplinary teams involved with the treatment of patients. Do you tend to use an MDT as a part of your process, or is it more of an individualised type of approach?
No, absolutely. We definitely utilise multidisciplinary teams. For Flinders, we do have an established lymphoma MDT. And so in these groups, we have several haematologists. We have the radiation oncologists who can provide their input in whether radiation can be delivered safely in this patient. We've got the anatomical pathologists, which are presenting the histology specimens. And we have the radiologists who present the CT scan and PET scan and MRI findings. So with all this information together, we can establish a treatment plan that is agreed to by the consensus group. We also have other types of MDTs where we involve our allied health colleagues, because oftentimes having a cancer diagnosis is very stressful for a patient and involves financial and legal matters, as well as how is this patient going to be cared for? Do they need additional OT or PT input? And we also involve palliative care, as that can be one of the treatment options is supportive cares. We also involve our infectious diseases colleagues in a weekly meeting, because many times, especially in the hospital setting, our patients have come in with infectious complications.
So it really is quite an extensive group we've got there. When I was reading about CLL as well, almost it sounded a bit like prostate cancer, in that it's actually, a lot of it can be quite indolent and long-standing, and that generally there'll be a large number of proportions of the community might have it without even knowing it and might not even have symptoms of it. Is that a way of thinking about CLL? It can be as low as grade as that?
More than 90% of my patients are found incidentally, and they go onto Lymphoma Australia and the various private Facebook groups, and they find that, neighbours, friends, they have CLL as well. It's only 10% of my patients that need treatment, and those 10%ers usually need second and third line treatments some way down the line. But if a patient has had CLL for a decade, that bodes well that they will never require treatment.
Obviously, we mentioned the ALL definitely requires treatment, and the lymphomas almost invariably would require treatment as well. Would that not be the case, or?
Most of the lymphomas will require treatment at some point. For some of the subtypes that are indolent, like the follicular lymphoma, marginal zone lymphoma is usually indolent as well. Many of them can undergo watch and wait, and that could be the case for a few years before the lymphoma progresses enough that it requires treatment at that stage.
So, Joe, where do you think things are heading for the future? Obviously, it's been a lot of advances. Will AI have a lot of input into this area? down the track? And is there other areas or new advances coming out, new medications or new approaches?
Certainly there's a lot of work in the genetic side of things where the more information we are gleaning from a patient's genomic status, the more we can tailor our approach. So, for instance, in CLL, there are the BTK inhibitors that I mentioned. There are also another class of drug called the BCL inhibitors, like venetoclax. And which one you start off with may be differentiated by what genetic status that patient has. And certainly you can develop resistances to those protein markers, and you would not want to treat a patient with a BCL2 inhibitor if they've got a BCL2 mutation. The other side of things where the future holds, there's a lot of input and research into CAR T therapies, which is chimeric antigen receptor T cell therapies. And this is, in a way, a form of a transplant where you take a patient's T cells, you send it away for engineering and manufacturing to make that T cell smarter and target the lymphoma or the leukemia. And then you reinfuse the T cells back into the patient. And so you're retraining the immune system to target that tumor and kill it. The other form of treatment that is emerging quite strongly is BiTE therapies, which are bispecific T cell engagers. And again, you're harnessing the T cells to target the B cell malignancies. Now, these technologies that I've both mentioned are against B cell malignancies. We don't have that kind of technology against T cells as yet. But that is something for the future with further research.
Brilliant. Well, it's been fantastic hearing about this little area. It's actually massive. In preparation for this podcast today, you might have heard me mention my reading. I have had to do a lot of reading as a general orthopaedic surgeon. I didn't know much about it, and it's great hearing about these different areas and the great treatment you're offering these patients. So thank you very much, Joe, for coming on Aussie Med Ed. It's been brilliant. I'd like to get you back at some stage to talk about the myeloid dysplasias and malignancies, and it's great to have you here today. So thank you very much.
Thank you for having me, and looking forward to the future.
Brilliant. Well, thank you very much. Dr. Joe Czerwinski, thank you very much for coming on, a specialist haematologist at the Flinders Public Hospital. I'd like to remind you that all the information presented today is just one opinion and that there are numerous ways of treating all medical conditions. Therefore, you should always seek advice from your health professionals in the area in which you live. Also, if you have any concerns about the information raised today, please speak to your GP or seek assistance from help organisations such as Lifeline in Australia. Thank you very much for listening to our podcast today. I'd like to remind you that the information provided is just general advice and may vary depending on the region in which you are practicing or being treated. If you have any concerns or questions about what we've discussed, you should seek advice from your general practitioner. I'd like to thank you very much for listening to our podcast, and please subscribe to the podcast for the next episode. Until then, please stay safe. I'd like to let you know that Aussie Med Ed is sponsored by Avant, Medical Legal Indemnity Insurance. They tell me they offer holistic support to help the doctor practice safely and believe they have extensive cover that's continually evolving to meet your needs in the ever-changing regulatory environment. They have a specialist medical indemnity team located here in Australia and have access to medical legal experts 24/7 in emergencies.